Now, the next topic to do is renal artery stenosis. Now, first of all, we talk about the essential of diagnosis. What happens in it? It is produced by atherosclerotic occlusive disease in about 80 to 90% of the patients, or fibromuscular dysplasia in about 10 to 15%. So the page was, guys, 949. Okay. Now the patient presents with hypertension, patient presents with AKI, and patients, we start AC inhibitors if stenosis is bilateral. So what happens when we start the patient with AC inhibitors and patient presents with AKI when there's bilateral stenosis? What are the general consideration? So, atherosclerotic ischemic renal disease, it accounts for about most of the renal stenosis. Basically, ischemic atherosclerotic disease, it is the most common cause of renal artery stenosis. Secondly, fibromuscular dysplasia, it is less common form of renal artery stenosis. So, Americans, they have hypertension with that stenosis, and what is the presentation age? That is 45 age. Okay, with a history of atherosclerotic disease in these patients. Other risks are CKD, diabetes, tobacco use, and hypertension, right? Now, what are the clinical features? Clinical features are, these are basically patient with atherosclerotic ischemic renal disease. They may present with number one, refractory hypertension. Patient has given lots of medicines, still patient is refractory to treatment. Or patient have new onset hypertension in the older patients basically. Or thirdly, the patient has pulmonary edema with poorly controlled hypertension. Basically, the problem is going on with the hypertension, blood pressure. No controlled blood pressure, refractory hypertension, new onset hypertension, and pulmonary edema secondary to the blood pressure, poor control. And the other point is AKI, acute kidney injury, upon starting on the AC inhibitors. First of all, we talk about the hypertension with the clinical symptoms of clinical signs and symptoms of RAS, and secondly, we talk about the usage of ACEs leading to AKI, right? So this is in addition to hypertension and physical examination. What we see, yes, very much important. Quickly, we do the abdominal examination, and if we suspect the case of RAS, what we do, we see the an audible abdominal bruit on the affected area, right? Now, another condition which is called as fibromuscular dysplasia, it is a condition which happens in the young woman. And patient, younger woman, she will be having the unexplained hypertension. What with the age, lesser than 40 years of age. So we quickly do the screening for that patient for the fibromuscular dysplasia. So next is lab finding. In lab finding, what we see number one, RFT is 1 ratio, and then creatinine, it may be elevated, and it will show the renal ischemia. If there's bilateral RAS, what will we see? We see number one. Yes, guys, this is important. We will see hypokalemia. RAS, we see hypokalemia, and finding that reflects activation of the complete renin angiotensin aldosterone system. This is another RAS. Okay, renin angiotensin aldosterone system. So patient have hypokalemia. Okay. All right. So next is imaging. What we do with the imaging, we just do the abdominal ultrasound. It reveals asymptomatic kidney, asymmetric kidney size, dose disproportional kidney size if one renal artery is involved. If other, affected more than the other, or small hyperechoic kidney if both. All right. So yes, patient asymmetrical kidneys. One is bigger size, one is lower size, but RAS, it has a smaller size, and what happens that we check out it and the imaging, and one kidney has smaller size. If bilaterally involvement, there will be small hyperechoic kidneys, smaller kidney, both kidneys, shrunken kidneys. Okay. Now they say that 3 prevalent methods for the screening are how to screen this case: Doppler ultrasonography, number 1; CT angiography, number 3; magnetic resonance angiography, MRA. So these we have to screen the patient with renal stenosis. We do the Doppler ultrasound, we do the CT angiography, we do the MRA, right? So American Cardiology, American Heart Association guidance, what do they say? They say that one of these should be undertaken if corrective procedure would be performed when a positive test results is found. They say that one of these tests, like these 3 tests, like Doppler, ultrasonography, CT angiography, MRA, It should be performed when the positive result is found. Okay, when the positive result is found, like for example, we suspect the patient has RAS and we do one of them testing, right? Now, Doppler ultrasonography, it is highly sensitive and specific, about 85 to 92, good like values. Okay, meta-analysis, what does it say? It say that it is inexpensive. That's good thing in it. Okay. Okay, patient-dependent operatable procedure, basically, we just like it should be like very much sophisticated procedure, so error can happen in it. Now, another thing is CT angiography. What happens in this? It consists of IV digital subtraction angiography with arteriography. Okay, basically we do it like this. Basically, this is non-invasive procedure. Now, what does it choose? It uses spiral helical CT with IV contrast section. Yes, we do the spherical CT, that is helical CT, and we insert the contrast in the body, and we check out what is the status of the kidneys, the arteries, basically in arteries, right? So just sensitivities from the various studies ranges between 77 to 98. The good sensitivity and specificity is also pretty much good, 90 to 94%. The next is MRA, magnetic resonance angiography. This is excellent, excellent. Yes, expensive for the screening of. So the gold standard would be MRA, but the negative point is it's expensive, right? In the atherosclerotic disease, basically we have most common is atherosclerotic disease. So yes, we do MRA. Sensitivity is 77 to 100 and flawed from 71 to 9. Just leave it. So they say that turbulent blood flow can cause false positives. And sometimes there's a turbulent blood flow happening there, just like a whirlpool, and it will show the false positive results. Okay, this is imaging agent of MRA, that is gadolinium stain dye, basically has been associated with nephrogenic systemic fibrosis. Okay, the side effect of gadolinium based contrast is, guys, just don't forget, this is also one I remember one MCQ. So nephrogenic systemic fibrosis it causes. Okay, and which occur primarily in the patient with GFR lesser than 15 ml. So this is end-stage renal disease when the GFR is less than 15 mils per minute, and rarely in the patient with GFR 15 to 29, right? So fibrosis has also occurred in the patient with AKI and renal transplant. Okay, now renal geography, what is that? It is gold standard for diagnosis, but is more intensive than the other three screening tests. So it's gold standard. It's very much good, exposure of this test, good dimension of this test, but it is not. It is more intensive. Sorry, yes, intensive or invasive. So this is it is performed after the positive screening test. Positive screening test is happens, we go with it. So we use the carbon dioxide subtraction. Basically, is called as carbon dioxide subtraction. Geography can be used in place of the dye. Basically, the dye has been replaced by the carbon dioxide subtraction. Because there's risk, patient do have the risk with the dyes, so we just use C2 or CO2 subtraction. So diabetic patient with the renal injury, in which we just use this test, this carbon dioxide subtraction geography, we do that. Okay, lesion may most commonly found in the proximal third of the ostial region of the renal artery. Okay, now what they say, conclusion, they're saying that in renal artery stenosis, where we see the region in when we do the renal geography, that is proximal third or ostial region of the renal artery. This is the lesion. Okay, now, what is the risk of atheroembolic phenomena? After angiography ranging from 5 to 10 years. After angiography, there is thrombosis, it can go to the embolism and cause lots of nasty processes in the body. Okay, next is fibromuscular dysplasia, has a characteristic bead on string appearance. Yes, guys, please note down here. This is the bead on string appearance of fibromuscular dysplasia. Now, what is the treatment? Treatment of atherosclerotic ischemic renal disease. This is controversial, but what are the options? We do the medical management, we do the angioplasty with the blood stunting, or we do the surgical bypass. So three things. So there are some trials. They say that vascular intervention was no better than the optimal medical treatment in the typical case with renal artery, saying that medical is better as compared to the surgical. So angioplasty might reduces the number of antihypertensive medications, yes, but does not significantly change the progression of disease. Hypertensive medicines reduced by angioplasty, but progression of disease happens. Okay, now next they say that stunting. Now we do the stunting. Now what happens? It has the Crohn's and Crohn's cons and prawns cons and prawns of that. So stenting produces a significantly better result with angioplasty. Okay, yes, definitely you do the stenting, it's better, it has a better result. Now next, however, the medical management, blood pressure control basically, and serum creatinine are similar at 6 months compared with both angiography and the stenting. Okay, so they say we do the medical treatment, but blood pressure and the serum creatinine, it remains similar for about 6 months as compared to with angiography and stenting, because there's no harm. We're just not using any kind of dyes or stuff, so they are normal basically level. Anyhow, angioplasty is equally as effective as and safer than surgical intervention. Okay, angioplasty. Now, what is the treatment of muscular dysplasia? Okay, they say that with percutaneous transcutaneous gastritis, remember it, treatment of muscular dysplasia, percutaneous transmural angioplasty. It is curative, which is in stark contrast to treatment with atherosclerosis. Yes, in atherosclerotic, it is not sure the same. We do the medical treatment. Sometimes, yes, we do the stunting, we just do the diagnostic, etc. But in the fibromuscular dysplasia, the gold standard treatment is percutaneous transluminal angioplasty. We do the intervention. Right, this is we have done it.